Good morning, students. I would like to introduce myself to you. I'm Dr. Thabat. I'm a graduate of University of Baghdad in 1984. I'm a fellow of Iraqi Committee for Medical Specialization in Oral and Maxillofacial Surgery. I have diploma degree in laser applications in medicine and master's degree in diagnostic oral pathology from the University of Sheffield. I'm a member of Royal College of Surgeons in Edinburgh, and I took the overseas registration exam in London. I will be teaching you oral pathology this year. And pathology is the study of disease. It's a bridge between science and medicine. In the last 100 years, we have significant reduction in illnesses, major advances in vaccination and treatment of inherited and life-threatening conditions. All this attributed to the pioneering work of the pathologist. As a dentist, we should be proud that we contributed to this field. Oral and maxillofacial pathology is a specialty of dentistry and pathology. And areas of interest for oral and maxillofacial pathologists include diseases that involve the teeth, periodontal tissue, mucosa and underlying structures, from the vermillion border of the lip back to the base of the tongue. Also, it includes diseases of tongue, maxilla, mandible, facial skeleton, facial skin, TM joint, and salivary glands disease. In everyday practice, diagnosis and appropriate treatment may be obvious from the detailed history and from clinical examination. More frequently, there are various possible diagnoses. In this case, a clinical differential diagnosis and a plan for special investigation should be worked out. These special investigations are like vitality testing of the teeth. For example, we have symptomatic tooth, or we have a tooth with dental abscess, and we want to know if this dental abscess is periapical abscess related to non-vital tooth, or if it is just a periodontal abscess, which is usually, the teeth are usually in this case, will be vital. Radiographs, we might take bite wings to identify the presence of interdental caries, or periapical x-rays to find if there is any periapical pathology. Sometimes we will need more advanced imaging technique like cone beam CT scan or ultrasound extra. In some cases, we might ask for a microbial culture. Example, we have an abscess, we gave antibiotic, there was no response to our antibiotic. Instead of keep giving antibiotic, the best thing is to take a swab from this abscess, send it to lab, and a culture and sensitivity test will be done. This will give us the kind of microorganism causing this infection and to which antibiotic these organisms are sensitive. Cases of sore mouth, burning sensation could be related to iron and or any other deficiency, folic acid deficiency, vitamin B deficiency. In this case, we might ask for hematological or biochemical test to identify the cause for this. Biopsy, as well as all other investigation, must address a specific question. So when we need microscopical examination, then we will take biopsy. Like for instance, if we have a recurrent aphthous ulceration, where the clinical picture is very clear, and microscopically there is no specific feature, biopsy is not indicated. But if we have a major aphthous, which may mimic carcinoma, so in this case, the only thing that like exclude the carcinoma will be biopsy. In this case, biopsy will be indicated. So what is biopsy? Biopsy is a process of taking a piece of tissue sample from living body for the purpose of histopathological examination and to provide diagnosis and to help plan treatment. Biopsy is a Greek word. Bios means life. Opsy means look. So we are looking into a live body. It's different from autopsy. Autopsy is like examining dead body to investigate cause of death. When histopathological or microscopical evaluation is needed, a biopsy is taken by the dental surgeon and microscopically examined by pathologists. Indications for biopsy are lesions, especially soft lesions, persist more than 2 weeks with no obvious etiology and doesn't respond to treatment, or a suspected neoplasia, like persistent hyperkeratotic changes in the mucosa or red oral lesions. When we have bony lesions that are not specifically identified by clinical and radiographical examination, or when we have lesion interferes with proper oral function and like persistent visible or palpable mass. Types of biopsy. We have surgical biopsy, fine needle aspiration, which could be like categorized as cytology or as biopsy, and oral cytology, which actually is considered as adjuvant and not a substitute for biopsy. Surgical biopsy. Excisional biopsy is used for small lesions which are less than 1 centimeter, where the whole lesion is excised with the normal tissue margin. It's considered as a diagnostic and treatment modality. It's a simple procedure. However, certain precaution must be observed. If we have suspicious lesion, would we take like excisional biopsy? I will advise not to take excisional biopsy for any small suspicious lesion or small carcinoma, because once the biopsy site has healed, then the surgeon will have no clue to the site of the area to plan his treatment. So always, if there is suspicious lesion, try to refer to the cancer team rather than do excisional biopsy in dental practice. The best example of excisional biopsy in dental practice for general dental practitioner is removal of the whole lesion for treatment and to confirm diagnosis is excision of a mucosal. Its clinical picture is very clear. It's known to be benign, and there is no prediction for malignant transformation. Now, incisional biopsy. This is when we take only representative part of the lesion. In case of large lesions, risky location, or great suspicious of malignancy. It's only used for diagnosis, and depending on the result, the treatment will be determined. We have different kind of incisional biopsy. We have the scalpel biopsy, punch biopsy, when we have a special probe to take a piece of tissue. This is specially used in vesiculobullous lesion, and trephine biopsy to take biopsy our specimen from bone. Frozen section biopsy is a biopsy specimen taken during the major surgery. When the patient is still on the theater table and a sample from his tissue sent fresh to the lab to be quickly frozen, and then cut and stained to be examined within 10 minutes of taking the specimen. The result will help the surgeon to determine the extent of the procedure and to verify the clearance of excision. So if the surgeon excise a malignant lesion, so he will send from the margin a fresh tissue to the lab, and then he will wait to for the result. If all margin clear, that's it. If there is cancerous or malignant cells in the margin, then the surgeon will need to go a bit further. Now, taking biopsy, the procedure will be, first of all, we prefer to give a block or regional anesthesia. But if it is not possible, then infiltration should be given at least 3 to 4 millimeters away from the lesion. And it will be given in 4 points: left, right, top, and bottom. Intralesional injection of anesthetic solution will produce hemorrhage inside the lesion, extravasation, and separation of connective tissue bands with vocalization. In some cases, general anesthesia may be needed, like for children or problem patients with gag reflex, or in some cases when the location is we can't reach it under local anesthesia. After giving anesthesia, we'll start planning our cutting. So always with the planning, plan to include normal tissue margin for the sake of differentiation between normal and pathological tissue. For benign lesion, the cut will be 2 to 3 millimeters of the surrounding normal tissue. In case of malignancy or vascular lesion, pigmented or diffuse lesion, cut 5 millimeters or more. Then, the site of the biopsy should include the whole pathological part or structure of the lesion. For example, we have an alveolar mucosa lesion which invaded down into the bone. It's not right that you will take the mucosa only. You need to send biopsy of the alveolar mucosa and the involved bone. And you need to choose the most suspicious area. In speckled leukoplakia, we will choose the red area. Always try to avoid taking from necrotic tissue. And the specimen preferred to be at least 1 by ½ centimeter and 2 millimeters in depth. This is for mucosal disease, and it should be, of course, larger for larger lesions. For large lesions, sometimes we might need several areas to be sampled. Now, after giving anesthesia and we plan everything, we will start the surgery. When you try to hold the tissue, try to be gentle with it and grasp it with a specialized retractor or forceps, or you can use suture or towel clips to hold it. Avoid flat end tweezers and avoid toothed forceps, because these produce crushing and alteration of the cellular architecture. Your assistant will be holding a section to provide you with a bloodless field. Be careful, the specimen might be aspirated by this section. To solve those two problems, it's advised to pass a suture through the specimen to control it first and to prevent it being swallowed or aspirated by the section. If you can see in this diagram, this is a false polyp. It's produced by the surgeon when he tried to grasp the normal tissue with forceps to study it during surgery. So he changed a sessile lesion into pedunculated lesion, which give a false appearance to the pathologist. So always be gentle with the tissue you are sending for microscopic examination. When you cut, it's preferred to cut a rectangular shape rather than triangular. This is to ensure a proper depth and to involve all parts and structures of the lesion. However, a deep, narrow specimen is better than broad, shallow one. When you cut, your knife should be always vertical. Try not to bubble or tilt your knife when you cut through the tissue. And avoid the use of electrosurgical blade or CO2 laser. It causes coagulation and destruction of the tissue as a result of high temperature. You might use this if it is large lesion because you will have enough tissue, like representative tissue for the pathologist, but for small lesion this is not advisable at all. If you will need suture the skin only. Don't suture through the lesion itself. When you finish, give your patient post-operative instruction. And now we will deal with our specimen. The first thing, never ever open or incise or divide the specimen. Always send it intact. This could happen when you have a small container and you took a big specimen. So that you might be tempted to cut it in two halves and put it in this small container. Don't. Always send it intact. And when you have more than one specimen removed from the patient, each specimen should be placed in a separate labeled container. Don't mix them, all of them, in one container. Always try to give orientation to the pathologist. So the front and back, superficial and the base of the lesion in relation to the site in the affected tissue. And sometimes illustration will be helpful, or sometimes some surgeons will use silk suture. Like in this specimen, like the note will be like the short end for, like represent this, like say superficial, and the long end suture represent like the deep layer or whatever. It's just an example. Now, fixation of the specimen. The specimen should be immediately and completely immersed in 10% formalin solution to prevent autolysis, maintain tissue structure and the cell details. Also, formalin may act as anti-infectious agent. Don't use water, don't use alcohol or liquid that destroy the tissue. Saline preserves the tissue only for a few hours and then it will degenerate. The opening of the container of the fixture should be larger than the biopsy to ensure easy insertion and removal of the biopsy without damaging it. Sometimes when the tissue lies fresh, you will try just to push it through this, through like a small opening. But just imagine when the tissue is fixed, it will be rigid, and taking it out of this small like opening might damage the specimen. So always try to find like a wide opening container. And other thing, try to avoid using any dark color container. It's always use translucent one, because sometimes when you push the specimen inside the container, instead of going or soaked in formalin, it will stick to the wall. And if it is dark colored, you will not see it and the specimen will degenerate. So make sure it's like you can see it and is totally soaked in formalin. Now after like specimen preparation and fixation, you need to send it to the lab. Label the specimen bottle with the patient's name, his date of birth, and date of like taking the biopsy and the site of biopsy. And send with it a case report that contains all the related clinical details, history and description of the lesion in the precise and accurate way and should be signed by the surgeon. And these are the details required by pathologist. Patient data, clinical details of the lesion, all like the description about it, any medical history with the details of the patient's medication, oral habits like tobacco, alcohol consumption, especially when you send like a specimen and like suspected carcinoma, because they are high risk of like a high risk in cancer. All the investigation, if done like x-rays, hematological examination, whatever you need to send it with the biopsy. The site and the type of biopsy, did you take excisional or incisional biopsy, and your clinical diagnosis with a differential diagnosis. If there is any previous biopsy, of course, you will send its detail to the pathologist. Now, contraindications. Like any minor oral surgery, there are relative contraindications for taking biopsy. A bleeding disorder, either due to like diabetes, like bleeding disorder, or it could be secondary to anticoagulation. Lesion located near vital structure that could be injured when taking biopsy, or medical condition of the patient not allowed, like given local anesthesia or taking biopsy. In previously irradiated area where there is a high morbidity associated with biopsy taken. Biopsy is not advised in multiple neurofibroma due to the risk of malignant transformation and the site of biopsy. Tumors of greater salivary glands, this is the only contraindication of incisional biopsy, because most common type of salivary gland tumors is pleomorphic adenoma, and this tumor has an unusual tendency to seed its cells and to reoccur in the incision wound. So such biopsies must be performed by a specialized surgeon. Causes of artifact in biopsy. As we mentioned before, it could be like crush or squeeze by forceps, fragmentation, injection, improper fixation, and freezing. All of those could cause artifact in biopsy. Cutting by CO2 laser beam or electrocautery produce thermal cytological artifact. If the specimen is so small, it will be unrepresentative and might result in wrong diagnosis. Improper specimen, like as we mentioned, we should avoid necrotic area because inflammatory reaction might mask the correct diagnosis. Of course, there are like other artifacts related to lapse procedure, but we mentioned here is just like the artifact related to surgical procedure. Now you send your biopsy and you receive the result from the pathologist. The result form should include patient's identification, the gross description of the specimen, then microscopic description, then the diagnosis and notes from oral pathology if you recommend like another or further investigation or anything to be taken like by the surgeon, and this should be dated and signed by the pathologist. What if the result don't corroborate your clinical impression? What will you do? First of all, you will check the patient's data. If there is any like mistake, like names or whatever, date of birth or whatever, then if you are sure that this is like belong to this patient, then you need to discuss it with oral pathologist. Oral pathologist might have a second opinion. Multidisciplinary team might be like consulted, which includes oncologist, pathologist, radiologist, and surgeon. Sometimes biopsy might need repeat, especially in case of malignancy. You can't go ahead with the procedure when you are not sure 100% from the result. Fine needle aspiration, as we mentioned before, some pathologists consider it as cytology, others consider it as biopsy. Anyhow, it's a penetrating needle in a lesion for aspiration of its content. Fine needle aspiration is a safe and reliable method of diagnosing suspected lesion in the head and neck area and greatly aids and speeds the implementation of appropriate treatment. The technique is easy. A needle, 21 or 23 gauge, inserted into the lesion, and then apply negative pressure by pulling the plunger. The needle then moved forward, backward, redirected to find the fluid cavity. After that, the needle is withdrawn, and then a small piece of tissue is expressed onto a glass slide. Then it will be fixed with 95% alcohol, stained with pap stain or hematoxylin and eosine stain, and examined within a few minutes. For deep lesions, we might need fine needle aspiration guided by ultrasound or radiological guidance to ensure that the needle enters the lesion. Now, the principle of fine needle aspiration. It can determine the content of the lesion, if it is a fluid, air, or solid. And if it is a fluid, it can ascertain the type of a fluid, if it is pus, clear fluid, or blood. It's rapid and usually effective aid to diagnose swelling in lymph node and parotid tumors. It's valuable when biopsy is contraindicated, like in pleomorphic adenoma. It allows exploration of radiolucent jaw lesions before surgical opening. There is no significant complications. It's a small size, so we can easily avoid damage to vital structure in head and neck. The cells can be fixed and stained and examined within a few minutes. The cells can be sent for immunohistochemistry and other special stains, or even for microbiological culture. Disadvantages are experience required for interpretation, small specimen may be unrepresentative, and definitive diagnosis not always possible. Now, oral cytology. Exfoliative cytology is a microscopical examination of cells that desquamated from epithelial surface, or it could be floated in saliva, or it is collected by scrubbing the surface of a lesion. Occasionally, it is used to examine cells or material of aspirates of a cyst. In healthy tissue, the deeper cells have a strong adherence, and they only become loose in the case of malignancy. Therefore, they exfoliate along with superficial cells. Applications of oral cytology are early detection and control of oral cancer, monitoring post-radiation changes, diagnosis of pemphigus and other vesiculobullous lesion, detecting viral and fungal infection, assessment of certain nutritional deficiency and diabetic status, and in forensic dentistry for personal identification. In a variety of situations, from brushing, biting a fruit, or from dried saliva, of spit. Because exfoliative cytology samples only surface cell and provide no information on deeper layers, simple exfoliative cytology has largely been replaced by brush biopsy. In a brush biopsy, a round stiff bristle, a brush used to collect cells from surface and subsurface layer. The brush is rotated in the fingers in one spot until bleeding starts to ensure a sufficient deep sample. The obtained cell then smeared on a glass, fixed and sent for diagnosis. The advantage of it is non-invasive, quick and simple procedure. Of course, there is no post-biopsy complication and local anesthesia is not required. It's suitable for patients having like medical systemic disease that when biopsy is contraindicated. It's suitable for diagnostic screening procedure to monitor large tissue areas of dysplastic changes. The disadvantage is small specimen may be unrepresentative, relatively less informative when compared with the histological slide, and a final diagnosis is not always possible. Positive cancer results are reliable, but negative are not. So if we get any cancerous cell in our specimen, then it's a proof that this is a cancerous area. But if the result were negative, we can't prove that there's no cancer in there. The only reason that it could be cancerous, but we couldn't get it in our sample. Then cytology is only suitable for epithelial tissue, and we can't grade the tumor because tumor usually graded according to the level of invasion, and as we can't see the whole tissue like architecture, we can't decide the grade of the tumor. Imprint cytology is the same concept of frozen section in surgical biopsy. We scratch or touch a glass slide over a cut surface of resected tumor immediately after surgery, and this will help detect tumor margin positivity in less than 20 minutes. Mass screening is cytology applied for suspicious cases or in a single patient with multiple affected sites. With the use of automated cytology, the false negative results decreases, and assess more slides and more areas per patient in less time and without any observer bias will help in diagnosis. This concept upset the pathologists because they don't want their experienced eye to be replaced by computer system. This is why they stated that for all positive cases or suspected cases, the ultimate judge should be the human eye and not depend on computer system. Now, interpretation of cytology. The cell biology activity is reflected based in the nucleus, and the functional activity is reflected in cytoplasm. And the basic nuclear feature defined by chromatin. If it is condensed, if it is heterochromatin, parachromatin, if it is active, if it is inactive. In this slide, we can see like a group of normal cells and a group of abnormal cells. And we can see in the abnormal cells the hyperchromatin, mitosis, change in nuclear cytoplasmic ratio. So these are the criteria the cytologists look for to give their diagnosis. In cytology, the criteria of cancerous cell are a high nuclear cytoplasm ratio. So the nuclei in cancer cells are usually large, numerous in number, and may also show abnormal mitosis. In cytology also we can have we can identify a marker for increased cancer risk and a marker for improvement in response to treatment. In viral lesions, we can identify some pathognomonic-like feature of viral infection, and also we can identify inclusion of virus in the cell. Other lesions, which is mentioned as cytology could help with, they are either they are not sensitive and not specific, and the diagnostic value is still questionable. The main artifact in cytology processing is improper fixing or air drying, which might result in increased nuclear cytoplasm ratio and increased wrinkling and produce a false positive result. Now, who should perform oral biopsy? Any dental practitioner possesses sufficient skills to remove and submit the tissue to the pathologist. Now, we need to stop on this paragraph. Sufficient skills. Like any dental school graduate will have the skill to hold the scalpel and cut a small piece of tissue. But is that enough? The sufficient skills in here is the knowledge, the clinical judgment, in addition to hand skill. Then another question, when would the dentist refer the patient to a specialist for biopsy? I'm not going to explain this. I want you to read this statement in red, remember it, and take it as a guideline for you. Thank you for listening, and I hope you enjoyed this lecture. If you have any question, please email me on my university email, and I will be more than happy answering your questions. Thank you, and have a nice day.